you are very busy with monkeypox, that's what I understood, so we're very happy that you are here, and you are going to talk about ending epidemics and preventing pandemics. The floor is yours.
Hello, can you hear me?
Yes, very good.
No, excellent. The previous speaker really set really the stage, but I want to add one single thing. We need to be mindful of the context. What might be applicable in Amsterdam might not, or New York, might not be applicable in rural really countries or rural areas in Africa. I think Tobias probably can concur with me there. I think help-seeking behaviors in Africa, I think more than 60% will go to the clinic when they have actually, most of them have sick behavior around, taking drugs, anti-malarial or antimicrobial before they actually see the medical doctor. And that's a huge problem around universal health coverage. But again, I think we can continue that conversation. Enforcement, I think, I'm not sure how that can happen in a rural area where people don't have access. They only have a small shop there in the corner with antibiotics. I think we need to think about it. But again, that was not the purpose of my presentation. I'm starting with 8 really in honor of Europe, I think, which I had the chance also through Professor Tobias to work with. I think the major point here, I think, is a major contributor in really public health on the continent. We have benefited from the science knowledge from Europe. So next slide, please. So you can see this picture, and then it's quite striking. That's exactly what we're seeing in the early really days of HIV. I think you can see clearly no antiretrovirals. The really most prolific business was the business of coffins. You can see closely in the shop there, at least 2 coffins being handled. It was very prolific. I think these days, you can see clearly, and agree with me, that you cannot actually make a differentiation between HIV infected individuals and those that are not infected, because exactly of antiretroviral, because a lot has gone through in the science and also in implementation science. We took the science back to the community to understand really what were actually the underpinning factor and ensuring that individuals in need of treatment had access. Next slide. So this is one of the slides that you can all agree that there's a global solidarity that played a key role here. So if you look at the y-axis, life expectancy, and then the x-axis, years, I think you can see clearly that in the early 90s, life expectancy really plumped. I think it's primarily due to HIV. And Zimbabwe, Botswana, and other countries, South Africa, pay a huge tribute in terms of loss in life expectancy. That is the way you can measure the impact at individual level of really antiretroviral or programs like PEPFAR, Global Fund. Because when actually those programs came to life, you can see clearly that there's a rebound, I think, in life expectancy. I think this is quite striking and very important that we keep this in our mind. Whatever we're doing, we should be able to measure it at individual level and also see how people can benefit from such very important global health program. Next slide. Next slide, please. So one of the first hero there, I'm not going to spend much time there, is Kofi Annan. You all know that's the one or the man who made the first financial contribution to the Global Fund. I think we're really proud of these Africans, which made very strong contribution, pushing at this position level to ensuring that people had access to medication, and then the Global Fund for HIV, TB, and malaria received substantial funding for the response to this pandemic. I will put it that way. But again, we have a program within the Africa Union and the Africa CDC around the Kofi Annan Fellowship is to pay tribute to that Secretary General Kofi Annan for that really movement in the global health space. Next slide. I think one of our hero again on the continent, it's really Joop Lange. I think with all the work he has done, again, is really, we cannot argue more, fix those, and all the point that Professor Tobias mentioned, and all the research studies on resistance, that's shown clearly that we can actually respond much better on antiretroviral. We actually through those really smart ideas. I think, again, these are people who really have to honor, and the African Union also is planning a fellowship for Joop Lange for Africans really to take that legacy beyond the continent. Next slide. Now, let me deep dive in the topic at hand here. The bottom line here, regardless if it's MR, any other disease, look at it at pathogens. For now, I'm dealing with pathogens. We need 5 things wherever we are. The politics, population, and my initial comment on AMR was related to population. We need to understand our own population. Even if you have the best policy, the best treaty and agreement, if you don't understand your population, it's not going to happen. We need partnership. We have seen how the global funds, how the PEPFAR program, how other programs have significantly contributed in actually really that rebound on life expectancy. And we need to do the pathogens as well. So those pathogens can guide us on how we're going to move on. So those 5 P's are extremely important in any policy making, in any actual implementation science, wherever we go. Next slide. So Africa CDC, I'm going to deal with the pathogens because at the Africa CDC, we're actually responding to outbreaks. And currently, we have more than 160 outbreaks every year. So, but we ask ourselves, can we be everywhere on the continent to respond to 160 outbreaks? You can agree with me that it's not possible. So we did some disease ranking and some risk prioritization across the diseases we're dealing with in all parts of Africa. So we came up with about 20 diseases. And then you look at it, really, some of these, you can't believe they have been there for years, for 5 decades. And really, shockingly, they don't have even just a rapid diagnostic kit. I mean, we don't even have a test. We don't have the drugs. We don't have the vaccines. And these can spark to a pandemic. And we all agree, an epidemic or an outbreak in the DRC can be the pandemic, and all of us, wherever we are, in Amsterdam or New York, can be directly affected. So we need to do something here. So if you look at the ranking, Ebola, cholera, COVID, yellow fever, Lassa, I think some in the room, even of our guests, they don't even know these diseases. So that's why the 5 P's, knowing your pathogens, knowing that you need those countermeasures, knowing that you need to diagnose if there's any outbreaks, knowing that you need to treat and prevent, to contain or curtail the spread of the virus is extremely important, particularly in this case for the African continent, because we're dealing with this. Mpox, for example, was isolated in 1978, and you can't believe it. Today, we don't have a diagnostic test for Mpox. Unbelievable. So next slide, please. So we did that risk trajectory, epidemic potential, disease severity, and the level of preparedness. So if you look clearly, really, they are not equal across board for the diseases. For some of those, there's the severity of the disease is there. For some, the epidemiological significance is there, and the potential to spark is also there. The level of preparedness is very low for most of these diseases. And you will agree with me that at some point, for Ebola, Marburg, and most likely also monkeypox. We could have probably have some stockpiling of vaccine somewhere across the continent to respond immediately to some of those diseases. In terms of preparedness, what I want to bring again here, which was mentioned by the earlier speaker, the fragmentation. Really, here is a fragmentation of information. We need to be sure, and then remember this, the outbreaks start at the community and usually end there again at community level. And that community is somewhere very far from the urban city, very far in the forest. So what do we do in terms of bridging that information gap? So I'm going to give you an example, Marburg. Marburg was sparked in Rwanda by an individual visiting a really cave of bats. So nobody tell you that there's among those bats, if you're not educated, that they can actually spread some zoonotic disease like Marburg. So one single individual can be, which was really the case for this outbreak, can actually spread the virus to a country, which might end up in the rest of the world. So it's in a rural area. Again, I want to point that it's not somewhere in the city. So next slide. So I'm putting that a little bit in a different figure with different visualization. So you can look at really the diameter showing the level of preparedness and also the severity. So obviously, one will agree that Ebola, cholera, of course, COVID, measles will have given highest priority in those ones, followed by yellow fever and other. But again, you are seeing this resurgence of some of those like measles, yellow fever, and cholera. And then shockingly again, cholera, more than 18 member states in Africa experienced an outbreak of cholera. And then surprisingly, there was a shortage of vaccines globally. I think, again, that's really a failure from the global solidarity to be able to really maintain some of the stockpiling for outbreaks globally. Next slide. So I'm moving a little bit now from that really global perspective on the risk, or the risk ranking. There's a risk. We all agree there's a risk. And that risk might, the patient zero might be in the bush somewhere where we don't even have access to, no access to medication, no access to care, and where actually things are happening. So I'm looking at dengue, where on the continent, I think you can see climate change was also raised by the previous speaker, the excellent presentation. You can see over time the spread of dengue across Africa, at least in this case for East Africa and the West Africa region. Exponentially, the spread of dengue. I think this is again a call that, again, the same story, yeah? No reliable diagnostics, no vaccines, no treatment, at least for the African population. So again, a lot of work to do here, and we'll talk about how to prevent. But I can start saying to prevent, we need to manufacture really some of those countermeasures. It's extremely important. We know already from the epidemiology that we're getting from the Africa CDC, what is the epidemiological significance, what is the severity, what is our level of preparedness. I think encouraging that the local production of some of those test kit or diagnostics, therapeutics, and vaccines. Currently, only 1% of all vaccines administered on the continent produced in Africa. 99% are imported. And we say this is not good for really health security for a lovely continent of 1.4 billion people. We need some political move. That's the first P, politics. We need really advocacy at political level to be sure that we really mobilize resources to be able to drive local manufacturing of those medical countermeasures. Next slide. So now let's deep a little bit dive, a little bit more deep dive here on what I've been saying. If you look at this map, it gives you the level of vulnerability. And you agree with me that the map, it speaks on its own. Again, the most vulnerable continent is Africa. And over the last 30 years, 30 new pathogens emerged, more than 75% from animal origins, And every year I mentioned 160 health emergencies, 90% are infectious disease outbreaks, 70% are zoonotic diseases. So the point here, which I want to emphasize, again, that was mentioned earlier, we need to start working really multi-sectoral collaborations. Because when we're seeing cholera, it ends with the ministers of health. But we have to talk about WASH, sanitation, which usually are not part of the Ministry of Health, core mandate. But we need to bring all those, environmental, agriculture. We're talking of zoonotic here. This is agriculture and animals, nothing to do with ministers of health, dealing with human health. So again, here, that fragmentation on the role and responsibilities, we need to start really moving towards kind of a unified approach, which we call One Health. I think it's important that we start pushing for that agenda. But unfortunately, in the pandemic agreement, this has been pushed back, which we are failing to understand. Again, that's the context we're saying population. In New York, it might not be a problem in zoonotic transmission, but it's a huge problem in Africa. So we need to think about it on the 5 Ps when we stay probably in Geneva and take some of these good decisions and some of these recommendations and policies to involve those on the ground, probably those at the community level. Next slide. So again, globally, if you look at the Global Health Security Index, and you can see also clearly here that Africa is really on the top tier, really bottom top tiers there. The graciously even offer 0 to 20%. Some will say we are really below that. So Africa average score is between 29.1 out of the 100. The global average score is around 38.9 out of the 100. So in Africa, no country is well prepared. And I've said it. When I say mpox, we're all using different assays, which are not even sometimes tailored, just used based on cross-reactivity. Because that level of preparedness, in my next slide, I'm going to show you there's a lot of domains and really factors that falls into the level of preparedness. So I'm going to bring that immediately probably to shed more light. Next slide, please. So you can have the laboratory, for example, the surveillance system, the legislation, even to response to outbreaks. What is the framework? Studies around AMR, we talked about it already, and then surveillance, laboratory, risk communication and community engagement. You can see that the greener part are really tiny somewhere on the right there, and the red are more prominent. So showing that we are not really ready in most of those domains in terms of the joint external evaluation of the international regulation. So again, we have a lot to do, yeah. And again, we need that global solidarity, and also really, I keep saying that as well, that the continent also should be mobilized to respond, take their own responsibility. African solution also to African problem. Marburg might not be a problem in the Europe or the US, but it's a problem in Africa. So Africans should sit, think, and mobilize resources and respond. Next slide. So we on mpox, we published a paper in Nature Medicines in March, and that paper was really, I'm very happy. This is one of the papers, in addition to what we published with Prof. Tobias, that I'm very proud to read every time, because this is the paper that gave the signal that mpox might be a global health security. We published it in March. We're very happy that several agencies across the globe, the European CDC, the US CDC picked it up, and they called for a regional meeting with the Africa CDC to actually discuss the way to contain the outbreak at regional level. But now you see they are spread all over. It was primarily in the Central Africa region with DRC. So we called for a meeting in April with 11 ministers of health, and then we took the really bold decisions to start moving towards a regional plan and then a continental plan to curtail the spread of mpox. Next slide. And you all recall, again, a very, this is why I've said earlier, we need to think bold, right? So Africa CDC took a bold step and published, or actually declared, a public health emergency of continental security. Because this is the mandate of the Africa CDC, given by the head of state. I'm saying continental, which is Africa. because there was a lot of questions why Africa has to declare. And we can declare. I want to take us back to the previous slide. Can you take us back to the previous slide, please? If you look at this one, in 2022, if you look at the number of cases, and you look at 2023, recall that in 2023, we actually had few deaths and also few cases. But there was a global declaration of mpox as a pandemic. And when the cases dropped in Europe and the US, nobody cares about Africa. The cases were still raising in Africa, but the mpox was declared over. So in 2023, 2024, the cases were increasing in Africa. We said we have to take our destiny in our hands, and we declared. And then that was, next slide, was followed by WHO on the 14th of August. Those are very important moments in global health architecture. We need to take our destiny in our hands. And that's the first time Africa is doing that. And then again, that's a very good start to reshape the global architecture. The lesson should also come from Africa, where the population are sitting, where the deaths are, where the cases are, to inform the rest of the world. Remember, during COVID-19, Omicron was isolated in Africa, and we informed the rest of the world. But again, shockingly, most of the countries were banned of traveling in the West. I think we need to be very mindful of how we really engage in this global architecture and health architecture. Next slide. So for mpox, we designed a continental strategy, a unified, for the first time again, WHO, Africa CDC, and 29 partners really agreed that we need one team, one plan, one budget, one M&E. What does that mean? The European Union can just fund the plan, and this is going to be helpful for all the member states affected, rather than having a different budget for Africa CDC, a different budget for WHO, a different budget for UNICEF. I think this is the lessons we're learning. And then subsequently, to really stop this epidemic and pandemic, we need to go for a unified approach. The good news is that we needed 600 million for this response, continental response. We got 1.2 billion US dollar. That's the value of working together. That's the value of a unified approach. This is now being used as a proof of concept for other diseases. Now it's mpox. Next time, if it's COVID, we don't wish that to happen. We're going to do the same thing and be sure that we work together to address this. Next slide. And the plan has 10 pillars: the coordination and leadership, risk communication and community engagement, surveillance, lab capacity, case management, vaccination, infection prevention and control, research and innovation, operation support and logistics. And the last one is continuity of essential services. You recall during COVID, and we're still paying, really, we've learned the hard way anyways, during COVID, we all focus the health system, our energy and resources on COVID only. Maybe in Europe, that wasn't the case. My apologies. But in Africa, that was the case. We mobilized all our health workers, all our very knowledgeable staff to respond to COVID. And then we're not actually paying attention to other diseases and even preventable diseases like measles, like polio. And then now we're dealing with really those zero doses. Now we have to go back now and fix those ones. And again, it's costing us more money. So we said no during COVID. For example, the same platform are being used for diagnostics of TB, for diagnosis of HIV, for viral load for HIV, and they're being used for mpox because we don't have rapid diagnostics. What we've said, let not disrupt the response to TB. Let not disrupt the response to malaria or HIV, because we have learned the very hard way during the COVID response. Next slide. So I mentioned this already. Out of the $599 million that we required, the breakdown is on the right. Now we have $1.2 billion US dollar, more than double the amount that we needed because of the unified approach. Next slide. So just in the next 2 minutes, I'm going to wrap up. So now in March, we had a region primarily reporting more cases. The Central Africa region, driven by the Democratic Republic of Congo, Burundi, and the Central Africa Republic. Now you get that spread to the 5 regions because of the delay, the response, because of the lack of the countermeasures. So now we're reporting over 50,000 suspected cases, 10,000 confirmed cases, and more, unfortunately, 1,000 deaths, which is more 5-fold the number where we declared the outbreaks in 2022. So what is most important for those who are not in the room are not getting this number, is that we have 50,000 plus suspected cases. But due to the lack of availability of the test kit, we could only test 1/5 to confirm. So there are still people out there, out of those 50,000, that we have not been able to confirm because we don't have the countermeasure for diagnostics to get to those ones being tested. A huge gap. And this can contribute to the spread of mpox at the community level. You can see the implications because all cases should actually be traced. The contact being traced and the contact of the contact. And now, if the case is not even confirmed, it means that he's walking around there as a free electron and spreading some really particles out there. So I think this is where you can see the impact of really impacting into local manufacturing. So, and then you can see more than 500 increase in confirmed cases in 2024 compared to the entire 2023. Next slide. So I'm going to go, we mentioned this already, we need to strengthen our surveillance system with community health workers. Also, again, be sure that the infection prevention and control are really part of the equation. I mentioned earlier the 10 pillars. We need an integration of community level surveillance, community-based surveillance. And then again, I mentioned already, on average, normally for a case, you need at least to monitor 20 contacts. On average, we're still at 3.3. So that is not good because all the new cases should be among the contact. If they're not among the contact, you're not breaking the chain of transmission. It means we still have an active human-to-human transmission. Next slide. So we talked about lab. I'm going to skip this just to say the most important message here is that in 2022, the mpox pandemic, gene expert, which is the point of care molecular diagnostic that we're using now, was designed based on clade 2. Because it's clade 2 that was responsible of the 2022 pandemic. But now, the pandemic here in Africa is different. It's a new virus within the mpox, the orthopox family. It's clade 1. But you cannot believe it. We're using the test kit, the point of care molecular that was designed for clade 2 to test for clade 1. We're lucky because there are some really similarity, but it's not 100%. So this is again what I'm saying about this global inequity that we need to bridge moving forward. And what we're mentioning, universal health coverage, very good slogans, but we need to be sure that it's reflected. This is 1.5 billion people we're talking about. Next slide. Again, here, for those understand again, I'm going to probably just 1 minute. There's that. This is DRC, where you have more than 90% of the cases of mpox. The system is built from the centralized model. The high throughput laboratory, which can test those that can test more than 500 samples in 4 shifts a day, are based in Kinshasa, which is the capital city. Unfortunately, few cases in Kinshasa. Now, in a huge country, larger like 5 times or 10 times Belgium, you move sample from the north to Kinshasa to be tested, which increases the turnaround time, which increases the risk of spillover. So you can understand the challenges on the logistics side and so on, which again, we are really trying to address. Those dots in the black, those are the lab Africa CDC you are setting up in the midst of this outbreak to be sure that we build resilient health systems and we leave a legacy after mpox to be sure that for any outbreak, we should be able to leverage on the existing to increase testing and throughput. Next slide. So I think this is a level of investment in laboratory. We're putting close to $3 million in less than 3 months to strengthen capacity in 3 African Union member states. Next slide. So now probably one of my last, vaccination. So we're doing ring vaccination. We're not doing mass campaign vaccination. And we plan to vaccinate 10 million children and adults, which is on average 14 million doses of mpox vaccines. But again, let me now acknowledge the contribution from the Global Solidarity Year. So it's different. In 2022, during the pandemic, 0 doses of the vaccines were made available for Africa despite the resources available to procure them. 0. So we responded to the mpox pandemic in 2022 based on all other measures except vaccination for Africa only. I think I want to give an assignment to all the remaining countries globally, 110, asked me whether there was any continent that didn't have access to mpox vaccine. Only Africa. I think this is again that global inequity we're talking about. So again, there's a change, there's a shift. Next slide. We've seen a really global solidarity at play here. The European Union Commission made more than 1,000 doses available of mpox vaccines to Africa, which is good. We are all happy. We comment and we issued several communiques to really recognize that solidarity based on their stockpiling of mpox vaccines. The Bavarian Nordic, the manufacturer, also made really a donation. Canadian government up to 200,000 doses. Gavi from their response fund, 500,000 plus doses. The US government, the outgoing administration, 1 million doses. UNICEF through their procurement mechanism, 500,000. So the list is long, at least it's good. You see, I can now go through a long, very long list. So in 2022, I had no line, 0. It was just 0 a number. So now at least we're proud for that global solidarity, and we're happy that this will continue, because an outbreak in Africa or in Goma might be an outbreak in Amsterdam, a lovely city, or in New York or in Washington, D.C. So we really have to be mindful in those responses, and we are all advocate to really push at your own level, your respective government, to make really a move into those directions. Next slide. And
your last slide, Nicaise, because time is up. Time is up.
My last slide, yes. Just to say vaccination is ongoing, and then we have 6 of the 19 member states that are reporting mpox that are now ready to deploy mpox vaccines. Again, thank you very much to Prof. Tobias, the entire team, for inviting us here, and we are really proud for the legacy left by the Europe. And as I've said, we're working towards a Europe fellowship for the African Union. Thank you so much, and back to you,
thank you
for your patience.
Okay.
And that's the map.
Thank you very much, Nicaise. I have to stop you now because there may be questions a little bit over time, so there's not a lot of time left. We're going behind. But are there questions? I think that I have actually one question about monkeypox. Which, if you remember very well on HIV and AIDS, this was first recognized in '81. At that time, HIV was already circulating in Africa for probably about 60 years. Now with monkeypox, we are in a completely different situation. We recognized the issue. I personally worked in smallpox eradication a long time ago, so I'm more worried than most people. But actually in the West, WHO declared it as an emergency, but here in Western countries, the idea is that we'll never reach really this problem. How do we convince the people that monkeypox is not only spreading in Central Africa, but it's a major problem for the world? What can you do about that? Did you get my question, Nicaise?
Yes, I got your question. No, thanks so much. I think first, if you look at the list of dangerous pathogens, mpox is among those ones. I think this is, again, for those who can read within the line, that's why you have a stockpiling of all those vaccines in the US and then in European countries, because it's a dangerous pathogens. So we all are aware that's globally is a threat, a spread of monkeypox. We all know that. That's where these vaccines being donated is from stockpiles of countries that have kept them in case there's an emergence or an outbreak in those areas. Also, okay.
Like the Netherlands, for example, who said that they didn't want to give the monkeypox, the pox vaccines because of in case they need it for themselves, actually for biological warfare. That's a completely...
Yeah, absolutely. You got it. So the most important things here, Chair, is that a very short answer for you is that what we call neglected tropical diseases for years, we need to revisit that. Number one, we need to be sure that we dedicate resources for research, development, science, and innovation, because that's what's going to trigger all those downstreams on diagnostics, therapeutics, and other research on vaccines. I think we need to invest into that from the global north, from resource mobilization on the continent, to be sure that we invest more into those so-called neglected tropical diseases. I think that's my short answer. We're all aware already it's a danger. I think we just have to work very hard and to really provide resources for research, science, innovation. Over to you, Chair.
Yeah, I think we're very happy that there is now an African CDC because that was missing a long time and it's extremely important. Constance, yeah, but where's the microphone? Oh, here. Sorry.
Thank you very much, Nicaise. A very, very nice presentation. I was very impressed by the funding that you got in from all the different organizations. And you suggested that you sort of have a united pledging. Do you think you have a blueprint for this now with this activity with mpox for future outbreaks in getting all these organizations engaged and actually contributing?
A very good question. I think we definitely, this is a very good model. What I'm saying, the IMST, which is the Incident Management Support Team, we're based currently in the DRC, and all these partners are around the table. Those 28 I mentioned, and we discuss, we strategize on the response together. But now on the funding, recall that all these partners, they sometimes go to the same donors, the same funders. You see Africa CDC goes to BMGF for the same proposal, WHO goes to BMGF for the same proposal, and then other partners. Now, all the partners, they were all in agreement that we need one single proposal. We don't want to fund multiple agencies. You guys have to figure out the best way to do that. I think that is very important. That is, again, the first time the donors actually pushing agencies to work together, and which is shown to be really efficient here. So we all mobilize resources together. We have the same tracker in terms of resource mobilization. I think this is historical, and I strongly believe that's the way to go. And again, it's part of some of those guidelines, policies that we have, the Lusaka agenda. And the Lusaka agenda is very clear. We really have to have one team, one plan, one M&E framework for responses to other diseases across the continent. Thank you.